Hi, my name is Dr. Nate Zoneraich. I'm the Chief Medical Officer for Advanced Fertility Care, part of the Pinnacle Fertility Network. We often get asked questions about recurrent pregnancy loss in our patients and what are the causes and how do we manage and potentially treat that. Causes can be varied depending on the age of the patient. So first, let's talk about a definition of what the technical definition of recurrent pregnancy loss would be, which is 2 losses before 20 weeks of pregnancy. We break it down into several categories as to what can be potential cause of recurrent pregnancy loss. Unfortunately, a lot of the time it ends up being unknown. The things we can pinpoint potentially are, number one, most common cause would be genetic causes, and those can fall into either inherited genetic causes or random spontaneous genetic abnormalities related to advanced age and just chromosomal abnormalities in the egg or sperm. If we focus first on the inherited part of a genetic cause, in those situations we would recommend doing chromosome testing called karyotypes of both intended parents, male and female, to identify if they have what's called a balanced translocation, meaning in their own cells, each cell has 23 pairs of chromosomes, but there can be shifting of the genetic information, which should be on one chromosome to a different chromosome. While all the information is there, it's kind of mixed up within the chromosomal setup. When eggs and sperm are developed in both male and female respectively, what happens at that point is the sperm has half the genetic complement, and because of those mix-ups of the balanced translocation, one sperm or one egg may have either more or less of a particular DNA from a chromosome, and when that gets paired with the opposite sperm or egg, now you have what we call an unbalanced translocation, meaning either too much or too little of a certain portion of the chromosome. That usually leads to a non-viable pregnancy, which often leads to, if it indeed does establish and implant, an early loss, either a biochemical, which is only a measurement of a serum level, versus an early miscarriage in the first weeks of pregnancy. Or of genetic abnormalities, which is usually the more common one, is what we call random chromosome events, or aneuploidy. And in that situation, what happens is, usually we focus on the women as eggs age, because women are born with all the eggs they're ever going to have. The rate of those eggs becoming more abnormal, having abnormal numbers of chromosomes, increases over time and over age. And that is usually, sperm can also be a contributor, but oftentimes it's the age of the egg that is the most pertinent contributor. That leads to what we call chromosomal aneuploidy. Things like people are familiar with Down syndrome, which is really 3 copies of chromosome 21 or trisomy 21, but there's a whole variety of any abnormalities in different levels that can lead to either no pregnancy at all, or what we call a early loss, either miscarriage or blighted ovum. It means an early loss of the pregnancy in the early weeks of pregnancy. That is unfortunately the most common cause, especially in the older age or at more advanced reproductive age females, is that part of loss. From a treatment standpoint, the good news is for either of the genetic losses, we can perform in vitro fertilization with pre-implantation genetic testing, meaning testing the embryos or a certain number of cells of the embryos to identify which embryos actually has a normal number of chromosomes and are not aneuploid. That's the word we use for abnormal numbers of chromosomes, or don't have a unbalanced translocation. So we are very fortunate to have such great technology that we can help people who have both losses related to aneuploidy as well as these balanced translocations to achieve a successful pregnancy by identifying embryos that are genetically normal before they're ever implanted in the uterus. Other forms of abnormalities that can lead to recurrent pregnancy loss include anatomical issues. And what I mean by that is some kind of structural abnormality, usually of the uterus, that is developed at birth or during the embryo development, that leads to either what's called a bicornuate uterus or a uterine septum. There are other variations of that, but really structurally is impeding the embryo's ability to implant in a normal spot and grow appropriately, depending on what the actual structural abnormality is and how extensive it is. And oftentimes there may be some surgical forms of correction that can establish a normal size cavity and then hopefully help to maintain a pregnancy throughout the course of the pregnancy after initial implantation. Additional abnormalities that we see are blood clotting disorders. We call it the family of thrombophilias. This can lead to microscopic blood clots at the level of the placental development when the initial implantation happens, all the way through usually late first trimester. In the workup of recurrent pregnancy loss, sometimes thrombophilia evaluation is indicated, usually for losses that are in the later first trimester. These thrombophilias can be both inherited, passed on through generations familially, and examples of that would be a factor V Leiden mutation. There also can be spontaneous, non-inherited issues that come up, and there are different blood tests that address these. Again, from a treatment standpoint, we do have the option of using things like baby aspirin, which is the least invasive form of preventing blood clotting, all the way up through Lovenox or low molecular weight heparin, which is a much more potent blood thinner that can be used in patients that are identified as having true thrombophilias. As I said, in most situations, unfortunately, a lot of these initial testing can be very frustrating because they all come back normal with no identifiable cause, and that's in our unexplained route. Usually the unexplained recurrent pregnancy loss is probably due to random chromosome aneuploidy, and that's where IVF with PGTA for aneuploidy comes in, meaning going through IVF, creating embryos, and actually testing embryos ahead of time to identify which of those embryos does not have a random chromosome abnormality, therefore increasing the odds of that embryo being successful and plant and carry a pregnancy to term. Another one of the questions we have for our couples or patients suffering from recurrent pregnancy loss is, I want to come in and do IUI cycles. So I hear that very often. Unfortunately, after we do the initial evaluation, all Clomid IUI or Femara IUI cycles really do are, one, increase the number of follicles or eggs that are mature that get released and are available for potential fertilization with the sperm in the fallopian tube. And the IUI or insemination is delivery of the sperm into the uterus to get to the fallopian tube to hopefully fertilize an egg. Neither of those scenarios really significantly improves outcome from a recurrent pregnancy loss, because often there are other factors, as we talked about, the genetic being the most important part of that Clomid IUI or Femara IUI, there's no way for those to address those. So we're not really addressing issues where people are having no trouble conceiving, but actually having issues losing the pregnancy. Additional questions we have is, how soon after pregnancy loss can someone start trying? That is really dependent on how far along they got into the pregnancy before they lost it, how they lost the pregnancy. Was it a biochemical, meaning HCG levels rose only without ultrasound confirmation of a pregnancy in the uterus? Did they miscarry on their own? Did they require a suction D&C, meaning to evacuate the pregnancy loss after confirmed fetal demise? Or is it later on in the first trimester where more aggressive or more invasive means of passing that pregnancy were involved? So that is a hard question for a blanket answer. It usually is a conversation between the reproductive endocrinologist or the patient's OBGYN based on what the circumstances of that pregnancy loss were. There's no doubt that recurrent pregnancy loss can be an emotional roller coaster and a huge burden for patients and couples dealing with repetitive losses while desperately trying to start a family or add to their family. Most fertility clinics within our network have emotional support social workers, psychologists that are readily available. We also strongly encourage patients to reach out through support groups, such as national support groups like Resolve, that have local chapters that offer a lot of support and resources to patients and people who are involved in this emotional journey and sometimes devastating news of when they lose a pregnancy. It's not really a major consolation, but it is more common than most people think. And as they start talking about to their friends, to their co-workers, to their confidants, they realize they're not alone. And in some way that offers some consolation that, especially as women get older, the risk of miscarriage goes up significantly. So they are not alone. It does happen. It is, if one thinks about it, it is Mother Nature's way of dealing with what would have been a non-viable, successful pregnancy. So in a way, and oftentimes miscarriages are the body's way of taking care of something that would have been devastating further down the line potentially. So it's just a different way of perceiving it. But for those who are struggling to have closure or struggling emotionally with this and physically with this, there are lots of resources through your clinic, through national organizations, through local community chapters that are available to help support through these tough times.